My name is Bhuneshwari Dhruv, roll number 25. I am going to present topic antianginal drug in continuation of previous video by roll number 26. So third one is calcium channel blocker. First phenylalkylamine, verapamil, benzothiazepine, diltiazem, dihydropyridines, nifedipine, amlodipine, felodipine. Mechanism of action. Voltage sensitive calcium channels are of 5 subtypes. They are L, N, T, P and R subtypes. L type is predominantly present in cardiac and smooth muscle cell. No exertion, contraction, coupling in the heart and vascular smooth muscle. Pharmacological action. Calcium channel blockers act mainly on cardiac and smooth muscle. They have little action on veins, hence do not alter preload. Verapamil. It is a phenylalkylamine and has predominant action on heart. It decreases force of contraction and decreases heart rate. This reduces oxygen requirement of the myocardium. Depresses SA node and slow AV conduction by prolonging effective refractory period. Second one is diltiazem. It dilates peripheral and coronary arteries, but its vasodilating property is less marked than dihydropyridine and verapamil. It also causes negative introtropic, chronotropic and dromotropic effects. Dihydropyridine. These are potent arterial dilator and reduce peripheral vascular resistance. A nifedipine. It is the prototype drug. It has a predominant action on vascular smooth muscle. Reflex tachycardia and palpitation are commonly seen with nifedipine. B. Amlodipine. It is absorbed slowly after oral administration. Palpitation and reflex tachycardia are less common with amlodipine. It is more potent and has a longer duration of action than nifedipine. It dilates both peripheral as well as coronary vessels. C. Felodipine. It has greater vascular selectivity than nifedipine and amlodipine. Like nifedipine, it can also produce tachycardia and palpitation. Pharmacokinetics. All calcium channel blockers are well absorbed through GI tract, but they undergo varying degree of first pass metabolism. All are highly bound to plasma proteins, metabolized in liver and excreted in urine. Uses of calcium channel blockers. First, exertional angina. The beneficial effect in angina pectoris with calcium channel blockers is mainly due to a decrease in myocardial oxygen consumption and also due to dilatation of coronary arteries. Diltiazem, verapamil and DHPS are used in stable angina. Variant angina. It is due to coronary spasm. Amlodipine, nifedipine, SR and diltiazem can be used prophylactically. They relieve pain effectively by attenuating the coronary vasospasm. Unstable angina. Calcium channel blockers are used mainly when symptoms are not relieved by nitrates and beta blockers or if these drugs are contraindicated. Fourth, supraventricular arrhythmias. Verapamil is the useful for supraventricular arrhythmias because of its depressant action on SA and AV nodes. It prolongs the refractory period and decreases the conduction velocity of AV node, thereby reduce the ventricular rate in atrial flutter or atrial fibrillation. Diltiazem is also useful but is less effective than verapamil. Fifth one is hypertension. Dihydropyridines, diltiazem and verapamil are used in hypertension. They control blood pressure by their vasodilatory effect. They can be safely used in hypertensive patients with asthma, hyperlipidemia and renal dysfunction. 6. Hypertrophic cardiomyopathy. Verapamil is the preferred calcium channel blocker as it improves diastolic function. 7. Migraine. Verapamil is useful for prophylaxis of migraine. Another calcium channel blocker, flunarizine, is more effective than verapamil in reducing the frequency of migraine attack. Potassium channel opener. Nicorandil is administered orally. It causes arteriolar and venodilation and improve coronary blood flow. Tolerance does not develop so its action. The side effects are headache, hypotension, palpitation, flushing, nausea and vomiting, ulcers in the mouth, etc. Others drug. Antiplatelet agent. Antiplatelet agent aspirin 162 milligram or 325 milligram is administered orally in patient with suspected or defined MI. If the patient is allergic to aspirin, clopidogrel 300 milligram is administered. Antiplatelet agent should be continued once daily. Combination therapy. A combination of nitrates with beta blockers. This combination increase the effectiveness and reduce the incidence of adverse effect. Second, a combination of nifedipine with beta blockers. Beta blockers can block the reflex tachycardia that is associated with nifedipine. Coronary vasospasm by beta blockers is prevented. Slow-acting DHPs are also combined with beta blockers. The combination is useful in classical angina and associated coronary vasospasm. A combination of beta blockers with verapamil or diltiazem. This combination should not be used as it may cause addictive depressant effect on SA node, AV node and cardiac contractility, leading to heart block, heart failure or even cardiac arrest. Fourth one, calcium channel blockers combined with nitrate. The net effect is an addictive reduction in the myocardial oxygen demand and improved coronary blood flow. This combination is useful in severe variant angina. Fifth one is a combination of nitrates with beta blockers and calcium channel blockers. This combination is especially useful in severe and resistant cases of exertional angina and also in unstable angina. A combination of tadalafil with nitrates can cause myocardial infarction and sudden death. Nitrates should be avoided for 24 hours after sildenafil intake. Pharmacotherapy of acute myocardial infarction. First, antiplatelet agent. Second, analgesia, intravenous morphine 10 milligram or pethidine 50 to 75 milligram for relief of pain. Nitrates, intravenous nitroglycerin for recurrent or persistent pain to treat left ventricular failure. Fourth, low flow oxygen therapy if there is decreased oxygen saturation. Fifth, reperfusion therapy, primary percutaneous coronary intervention or thrombolytic therapy. Sixth, anticoagulants, low molecular weight heparin or unfractionated heparin is given to prevent reinfraction and thromboembolic complication. 7. Beta blockers should be administered during first 24 hours unless contraindicated. They prevent reinfraction, arrhythmias and reduce mortality. ACA inhibitor, example ramipril, or angiotensin receptor blocker, example valsartan, are administered early to improve survival. Acidosis is treated with intravenous sodium bicarbonate. Thank you.